Welcome to DentalXP.com. I'm Dr. Maurice Salama, and today we're going to be taking you through a presentation geared at some of the new regenerative technologies and concepts in bioengineering in 2012. I'm going to talk to you a little bit this evening about options and interdisciplinary solutions regarding these types of challenging and very common clinical scenarios in which regenerative technologies and procedures are needed in order to enhance the implant recipient site. I'd like to remind those who are watching the webinar tonight that there is a hands-on bone grafting program here in Atlanta with myself, January 11th to the 12th, 2013, which will really cover much of what you'll see tonight as part of the program, and part of the program as well will involve the utilization of new materials and some of these techniques on models utilizing some state-of-the-art instrumentation. So I welcome you to that course for those that are interested. It'll be 2 days. Also, for those that are interested, I hope that you'll take the opportunity to be with us in Las Vegas, Nevada, February 7th to the 9th in 2013 for the first ever Global Dental XP Symposium. We were very proud to have a list of speakers that I believe may be some amongst the best in the world. People like Eduardo Anitwa, Dennis Tarnow, Stephen Chu, Pat Allen, Mike Picos, Craig Mish, and it goes on and on and on. So I hope you'll take the opportunity of being there. The first day of the program is very unique, in which it'll be offering an entire day, 8 different hands-on programs, which will be part of the tuition for the 3-day conference at the Cosmopolitan Hotel in Las Vegas. So if you're interested, you'll see a banner to the right of your screen to give you more information and allow you to register. Also, of course, we know it's Vegas, so we're looking forward to having some fun with the participants. There will be quite a large social event schedule, and we hope that you'll help participate and enjoy your time, not only in a great learning environment with the high level of speakers that will be with us, but also to have some fun and be able to interact with the global community that is now over 90,000 dentists in over 160 countries. In order to start describing and discussing the importance of bone grafting, I think it's important for us to agree upon the diagnostic terms that will be utilized throughout this presentation, and certainly diagnostic terms that will help us in dealing with the severity and the prognosis of these cases based upon their diagnosis. For our group in Atlanta, we classify the defects in implant dentistry and reconstruction as type 1, being ideal sites where the buccolingual and vertical dimensions are ideal. And in these cases, obviously, preservation techniques are mandatory, trying to preserve what we have. And as you see in the case to your left, a ridge that was augmented at the time of extraction with bone and soft tissue, and now maintaining it so that implants can be placed in an ideal position. You can see on the left screen the implant inserted, the interproximal bone, the buccal bone maintained. A type 2 defect for us would be one that entails a buccolingual or horizontal defect only. In these cases, it could be dentate cases with teeth present, where we have bone loss on the labial, followed by soft tissue recession, as in this case. It could be a tooth that has never formed, or an extracted tooth that had traumatic extraction, loss of the labial plate, or of course a severe traumatic incident in which the labial plate is entirely damaged and fractured, as you see here. For us, this is a type 2 environment. Although challenging, we feel has a high degree of success, and the prognosis with some of the techniques that I'll describe today are quite high. And of course, for us, the type 3 defects are always the most challenging. These are ones where interproximal bone has been lost due to periodontal disease, or of course, the vertical dimension has been lost due to traumatic incident, as you see here. In these cases, we continue to find them the most challenging. The prognosis is guarded. These may take multiple surgical encounters, and in many cases today may in fact require some form of prosthetic gingival reconstruction, something that has been described on our site through articles written by myself and Dr. Christian Coachman and the rest of the team here in Atlanta. So let's begin with a type 2 defect. I think one of the most important aspects of today's diagnostic technologies for us to be able to identify the severity of the defect even before we enter the surgical operatory. In our office, we are utilizing Carestream 9300 cone beam CT, which really to us allows us to identify and diagnose these defects prior to entering into a treatment plan. And you can see on the left screen utilizing this technology plus the utilization of materialized 3D software to really fully identify and colorize the defects, as you see here, showing that this is in fact a simple extraction but a very severe class 2 type 2 horizontal defect. We can see this both on the right screen on the CBCT image in the cross section, as well as on the left screen in the 3D rendering. So the extraction of the tooth is quite simple and ordinary, we all know that, but really what we are trying to understand is before entering this area, how in fact should we best utilize the techniques and technologies available to reconstruct. Of course, we know Arojo and Lindy in 2010 in clinical oral implant research spoke about the use of BioOs collagen at the time of extraction. This was a dog study. In 6 months of evaluation, the placement of a biomaterial, what they found as a summary, in fact, in the extraction site, may modify the modeling and counteract ridge contraction of these defects. So the utilization of some form of bone grafting material, whether it be slow resorbing or something that is a high turnover product, is something that should be considered. One of the first things I always discuss is based upon the level of infection in the area. One of the biggest concerns and one of the top reasons for failure of socket grafting is the lack of attention paid to degranulation and debridement of the wound. Many times there is granulomatous and infected tissues that reside at the base of the extraction site. These need to be properly removed and excavated utilizing a series of serrated spoon excavators and scalers, as well as piezoelectric technologies and copious irrigation. And you can see on the right side of the screen tremendous amount of granulomatous tissue being removed from the base of the defect. The augmentation in this case, our ability for us to augment this in a most simple way, would in fact be utilizing some form of resorbable collagen barrier, something that's rigid enough to maintain a bone graft substitute in place and protected during the initial 3 to 4 months of wound healing. One such membrane that I've been excited about using, which simplifies this technique, is the socket repair membrane from Zimmer Dental. This is a product that was first introduced by Dr. Dennis Tarnow. A very simple, preformed, rigid membrane. I soak it in a bioactive modifier, in this case PRGF, or plasma-rich and growth factors, a BTI product. I place this on the labial aspect, as you see here, pushing it underneath after it's been completely debrided. And now I can introduce a mixture, in this case, of mineralized irradiated bone, or Puros, mixed with PRGF, which allows me to carry this into the extraction socket defect, and it's completely stuck together, which is one of the nice things about the PRGF material. It's very sticky and allows us to carry the bone graft material and keep it together during the grafting phase. You'll see on the right side of the screen this bone graft is placed, mixed with the material. It starts to incorporate the blood from the wound edges, and I have the last part of the membrane that I can now fold over the top to allow me to seal the top of the extraction site. On the left side of the screen, you can see that we folded over the top of that socket repair membrane. It's very easy to use, and then on top of that we've placed a plug of the plasma-rich growth factor. So the PRGF plug is now protecting the wound and allows me to seal it with a simple crisscross mattress suture utilizing 4-0 Vicryl. And you can see as well on the left side of the screen, we've really been able to do this in a very, very non-invasive approach, minimal dissection here. We've maintained all of the contours, and we now have the bone graft substitute, the membrane, and on top the mixture of the PRGF and the plug to protect the wound. And one of the things you'll see here is that we were able to overbuild the contour when we packed the bone in the area of that labial deficiency. So really being able to address this utilizing a simplified approach. Approximately 4 months later, again utilizing a limited view CBCT with the Carestream 9300, we can now place the implant transmucosally without having to reflect the flap, again a non-invasive approach, and the implant is inserted transmucosally, and you can see here the tapered implant being inserted, and here is the lineage of the case, day 0, the diagnosis, extraction, followed by the collagen membrane socket repair, the bone, and the PRGF bioactive material. At day 120, you can see some excellent post-operative healing. You can see the bone graft consolidating not only buccolingually, but even somewhat vertically above the level of the adjacent interproximal heights of bone. And at day 180, the implant is inserted, and you can see here the implant with the bone completely to the top of the head of the implant, and an HLA contour abutment with an hourglass shape being inserted for the final restoration. And here, the day of cementation, you can see how the soft tissue has been addressed utilizing temporization. You can see we've been able to maintain the heights of contour and the scallop of the interproximal tissues because we've been able to do this in a very non-invasive approach, maintaining the buccolingual and being able to augment this utilizing a very conservative approach. The idea for us to be able to augment buccolingually is obviously critical. It is a very common regenerative issue in implant dentistry. We are often faced with buccolingual deficiencies as it's commonly found following extraction or trauma of teeth. So if we can do this in a simplified way, we believe that the success rate of these procedures is extremely high and the prognosis excellent. Here you see the before and the after, our ability again to maintain and regenerate all of the buccolingual deficiency while also being able to maintain the soft tissue contours. Another method that we can look at for larger deficiencies, if you see this case here, really what we're looking at is a very significant loss of the buccolingual dimension due to the failure of a previously placed dental implant. If we take a look at this again on cone beam CT, it allows us to diagnose the case as a class 2, type 2 horizontal deficiency. It allows us also to understand the amount of bone that is missing and how much bone will be required to regenerate the defect. You can see here that the bone loss goes all the way to the lingual plate. It's a very large buccolingual deficiency, and there are many different ways for us to address these defects. If we take a look at this in the mouth, we can see that there has been also, in addition, the loss of the vertical heights of interproximal bone on the adjacent natural teeth. So therefore, when we take a look and combine the diagnosis, not only from the CBCT, but also from the clinical perspective, interproximal bone sounding, the soft tissue response in this area, we see that we actually have a type 3 defect. A type 3 defect meaning that there's a vertical component to this deficiency which must be managed as well. And oftentimes this will limit the prognosis. We cannot promise the patients the ability for us to completely regenerate the lost architecture, and this may require some form of artificial gingiva or restoration of the adjacent teeth as well, or some form of orthodontic extrusion following implant placement to bring down those interproximal peaks of bone. If we take a look at this at the time of surgery, you can see that there has been bone loss all the way to the lingual wall. We can see the interproximal bone on the adjacent teeth have been affected by the infection and loss of the implant, and therefore these peaks of bone will be critical for our ability to regenerate interproximal soft tissue. and we may in fact need to alter the treatment plan later on. This is something that's discussed with the patient as a secondary phase of treatment. From the standpoint of technique, today many different techniques are available for us to harvest bone, and we use cone beam CT and 3D imaging to really help us and assist us in the planning of these cases. Here we can see we're considering block augmentation, utilizing bone harvested from the ramus. And one of the nice things about cone beam CT, it allows us to track the mandibular nerve in this area so that we can make the decision based on safety and availability of the amount of bone necessary to reconstruct the defect. We can take cross-sectional views here, so many different views can be done on the 3D rendering, and you can see here this is the dense cortical rim of the ramus and then the cancellous bone inside. You can see how the mandibular nerve tracks. We have a very nice area where we can harvest bone safely without, in fact, getting close to the nerve. So this is how we're looking at the case. If we're able to utilize this lateral or buccal aspect of the ramus, you can see we're well above the nerve. We have a good amount of bone that we can harvest, both cortical and cancellous, and we can do this in a very effective way. So here's the view in the mouth. We're very aware of what it's going to look like once we make our incision. We're going to plan the incision. It'll be sulcular from the bicuspids through to the molars, and then a cutback incision that will be made distal to the second molar up the ascending ramus. Now we're taking a look at the bone in the mouth that was identical, and we know exactly where the nerve tracks and how much bone is available for the harvesting. So this is all planned pre-surgically. Now, one of the tools that makes harvesting of autogenous bone, which we often mix and utilize as a scaffold for GBR techniques, can be harvested with, in this case, the Meisinger bone transport system. This is something that's sold here in the US through Salvin Dental, and this has really made my job of harvesting bone, at least in these kinds of one wall or single site defects, very, very simple. You can see this is a system that actually has many different diameters in terms of the size of the defects, the amount of bone you're going to be harvesting, and it allows us to match the size and diameter of the trephine with the size and diameter of the drills that will prepare the recipient site to receive the bone. So here we can see with the depth markings on the trephine drill, I can go to the back of the ramus based upon the 3D rendering. I know exactly how deep I'm going to go on the markings. I'm going to go approximately 10 millimeters, and you can see that marking quite readily on the image to the right. And now I can know I'm safely above the nerve and I've harvested enough bone for the recipient site. This is easily now fractured with a chisel that we utilize, and here utilizing the DevaMed chisels, I can just infracture this, remove it in its total, again making this very simple for me and atraumatic. I can now harvest this very dense cortical cancellous bone block. This is an approximately 8 millimeter core, and you can see that it's taken out very cleanly, and we've even left the outer wall, which isn't always necessary. If you need to take that, you could, but I feel that if I leave behind a 5-wall deficiency, it's better for wound healing. We're then going to drop a piece of PRGF plug into that donor site. That just helps with the initial healing and minimizes post-operative discomfort and maximizes wound healing. If we take a look at this on an animation that was provided to us by Console Pro for Dental XP, the concept is clearly what you see here. You can either take the entire core, or you can actually also outfracture the labial part of that core. Typically, I won't use a disc. I'll use the PiezoArt unit from Duell to just do that posterior cut. And now I'll go ahead and I'll match the drill for the recipient site with the size of the trephine drill. And that's what we're doing here. It allows for intramural penetration. It allows for the bleeding and the entering of mesenchymal cells from the surrounding cancellous walls. And now we're going to smooth down the bone block and then insert it into the recipient site. And shaping of this really doesn't have to be too significant. It's pretty much the shape of the defect. I like to over contour it, and also, of course, we want to secure it with 2 fixation screws. We can then place additional bone, particulate bone. This could be either mineralized irradiated bone or maybe a xenograftic product. And then, of course, over the top of that, the utilization of a barrier membrane or, of course, a bioactive material. So the collagen membrane is then placed over the top, and then primary closure should be achieved. So we're going to go back to our case. You can see we've achieved 10 millimeters of length, 8 millimeters of diameter. It's a very nice sized block. We have cortical and cancellous bone. We're now going to prepare the site utilizing the corresponding drill that prepares the recipient site that matches identically to the drill, the trephine that was used for the core. Here's the drill in place. We're going to make a vertical step. As you see here clearly, there's now a vertical ledge at the bottom. We have some bleeding from the palatal wall. I make my intramural penetrations, as you've just seen on the animation. And of course now 2 bone fixation screws are inserted to make sure that we have 2-point fixation and very, very stable block graft. This is one of the most important parts of the procedure. These blocks should be entirely stable with absolutely no movement. And I'll show you later on that we're using today 1 millimeter screws from Meisinger, again available through Salvin Dental in the US. So you can see here we've attempted to over contour. I like to place more bone than is necessary because of the likelihood or the possibility of bone remodeling and resorption, especially of a block. And we like to leave these blocks in place for a period of 4 months before re-entering the wound. Again, particulate bone, just like the animation, being placed around mixed with PRGF so that it stays in place. The bone particles don't swim away. They're impregnated in bioactive material taken from the patient's own blood. And you can see we've been able to contour not only buccolingually, but we've added bone vertically to attempt as much as we can to rebuild, if possible, some of the vertical deficiency. And here you see it clearly. Overbuilding the site, to me, by 25% is critical. I think you've seen some of this work on our site by Dr. Picos and Dr. Mish, who've also explained the need for the overbuilding regeneratively of their bone graft sites. I utilize, in this case, autologous fibrin harvested from the PRGF protocol. Again, this is an autologous membrane that's taken from the blood. It has growth factors. It has a resorption rate of about 3 to 4 weeks. And we can use this by itself in multiple layers, or we can use this in combination with a collagen barrier. With block grafts, I prefer to use it by itself. I don't think there's a need in many cases to add a membrane. If I'm going to use something over the top, in many cases I prefer to use, as you see here, a dermal product or an acellular dermal material to not only protect the bone graft, but to thicken the soft tissue as well. So we're going to now go ahead and add the dermal material mixed with the PRGF, and then we release the flap very aggressively to attain primary closure, tension-free. Gore-Tex sutures are utilized, my preference, with most bone graft cases, and certainly ones of this severity. At approximately 4 months, you can see what it looks like. We've had some resorption, but overall very, very nice wound healing. We've had the ability to now remove those screws, which are very small, but they do an excellent job And you can see we have excellent area now and regenerated the site for implant placement. The implant can be placed, in this case, a 3.3 millimeter implant for the lateral incisor with a minimum of 3 millimeters of bone, in this case well beyond the buccal aspects of the implant, which is excellent in terms of long-term preservation. So you can see from the pre-op view on the left screen, tremendously large defect, and on the right screen being able to come back in 4 months and place an implant in the newly regenerated ridge. Let's take a look at an additional case and go through similar steps. This is not something unusual. A patient that will come into our practices on a Monday morning. They have a fractured central incisor that needs to be replaced. You can see that severely damaged. When we raise our flaps again, cone beam CT, to me, if you look at this two-dimensional image in the middle screen, just simply inadequate to identify the level of this deficiency. And we can get fooled. If we simply don't bone sound and take a CBCT, we may be under the assumption that this is a fairly easy case. We may be under the assumption that this is one where we can do it incisionlessly. And I think this is where many people make their errors and mistakes. I think that these cases are the types of cases that we can run into problems in trying to navigate them without proper diagnostic tools. You can see on the far right screen that the entire labial plate has been damaged due to the fracture of this tooth, and we have a tremendous amount of granulomatous tissue. You can see the level of destruction of the root once we raise the flap. And what I first look at when I see these deficiencies, when I think it's very important, is not just to focus on the loss of the labial plate, but to really focus, even more importantly, the areas that are very difficult to regenerate. The buccal plates are very predictable. Buccolingual type 2 deficiencies are very predictable. But when we lose the interproximal bone, like the previous case, that limits our ability to completely regenerate the implant receptor site. And here we can see the red arrows pointing to the interproximal bone of the adjacent teeth. And this is critical because if it is intact, it remains a type 2 site, and if it's damaged, it makes it a much more challenging type 3 vertical deficiency environment. So we're looking at the horizontal component in the black lines to the left, and this is again to me a type 2 defect. We completely degranulate the area as you see here, and we start to focus on problem solving. There's a couple of different ways to address this type of deficiency. If it is a narrow defect, a narrow meaning that the level of bone on the labial that's missing is very vertical in nature without a wide base, there's a potential to do this regenerative protocol in combination with implant placement. So if it is very narrow, as you see here with the arrows, then it's possible to combine implant placement with regenerative technologies. If in fact the base or the middle part of this labial deficiency is quite wide, then I prefer a staged environment. So here you can see we place our implant. I always like to place a straight, narrow, non-flared healing abutment at the time of placement. I secure, in this case, a collagen barrier, long-term collagen barrier, like the 4 to 6 months of time before resorption. I'm going to secure it with an AutoTac system from BioHorizons, and I'm going to create space for my regenerative material that's mixed with plasma-rich and growth factor, the blood-borne bioactive material. If you don't have an ability for that material to harvest it yourself, then certainly there are other bioactive products available on the market today, such as BMP2 from Medtronic, or of course there's materials like Gem21 that can also be utilized. If we take a look at something similar from an animation, again, provided to us by Consult Pro, you can see the defect, very similar defect here when we take it out, a very narrow defect where the implant is inserted. And now they place their implant and they perform the graft, as you see here, in combination with implant placement and a collagen barrier. And we're going to do the same thing here. The membrane is inserted, 2 tacks are placed. Healing abutment is placed on top of the implant to support the vertical component of the soft tissues during wound healing. Fibrin is then placed in multiple layers over the collagen barrier and over the healing abutment to protect the graft site. And then we close over the top utilizing coronally positioning the flap and vicryl sutures. This is the area in approximately 4 months. You can see we've been able to maintain the contours buccolingually as well as vertically. And now we can start the process of shaping of the tissues. We expose through minimal surgical entry to expose the top of the implant, placement of an HLA contour abutment, and of course now we can take an impression of that abutment and send it to the laboratory. A temporary can be fabricated off of that, and at that time any soft tissue procedures that need to be done, I always believe second stage surgery is an optimal time. If you have a frenectomy that needs to be performed, here we're doing it utilizing a DECA CO2 laser. We can go ahead and place a temp base cap onto the HLA contour abutment and pick up a polycarbonate temporary crown, and this starts the process of tissue shaping and tissue molding. You can see that I didn't re-enter the site. I left behind the auto tacks. This is something I've been doing for many years. If they're stable, they seem to stay in place. There's no reason to raise a flap to remove them. So I leave it through a singular surgical approach. Here you can see at approximately 3 months in the temporary, the soft tissue has been shaped, and you can see we have ideal contours both buccolingually and vertically. Interproximal bone sounding is performed just to verify that we have appropriate bone support for the soft tissue papillas. Again, what we knew at the time of extraction was a type 2 site is further verified by the fact that the tissue has responded positively. With a patient with a high lip line, we're able to perform the procedure with a high level and high degree of aesthetics, both in terms of soft tissue, color, and of course shape of the final restoration. Again, looking at it buccolingually, the maintenance of the contour of the ridge by grafting and performing guided bone regeneration. Lateral view, again from the side, displaying optimal aesthetics at approximately 2 years post-op. And you can see again now at 3 years post-op, the right central incisor is a very, very aesthetic restoration for this individual, and she is quite pleased with the long-term aspects of the color, shape, and the relationship to the adjacent natural teeth. At the time of cementation on the left screen and on the right screen at approximately 3 years post-op. Sometimes we are faced with different forms of regeneration that we need to perform. In this case, we see a patient who had an implant placed during orthodontics. The implant site became infected and this implant needed to be either removed or augmented. And at the time, since most of the implant apically was entirely in bone and we wanted to minimize trauma or the creation of a larger defect, we decided to take the opportunity to disinfect the body of the implant with tetracycline and the utilization of an Nd:YAG laser to detoxify the implant surface. So here you can see the implant, most of the apical part of the implant engaged in sound bone, the top part of the implant exposed. We place the tetracycline after debridement. We leave that on for 3 minutes before rinsing with sterile water. And then we apply the Nd:YAG laser energy to detoxify the implant surface. One of the interesting methods to maintain space and to be able to do that in combination with an implant, whether at the time of implant placement or in a case like this where we're repairing a ailing implant that has been infected during the healing phase, is to utilize a titanium mesh that is secured to the implant through a cover screw or cover cap. Here you can see that these membranes are easily pliable. This is the C3 or the CTI mesh. We can then place bone underneath this. Again, I'm going to utilize a combination of mineralized radiated bone in combination with PRGF. And I'm going to overbuild this area, and I'm going to fold over the titanium mesh over the bone graft and secure it with the cover screw or cover cap. Here you can see what it looks like before the mesh is folded down. It's easily moldable, and this is a rigid form of a permanent membrane, and it also has vent holes to allow for the blood and other nutrients to come through this material and engage the bone graft material. So it is a permanent membrane, one that is rigid and maintains space, and one that can be attached and connected to the top of the implant. Again, I'm going to use the similar techniques I've used before. We can utilize fibrin, which is autologous and has growth factors in it in multiple layers to protect the bone graft and nurture the bone graft with bioactive materials and growth factors, as well as to enhance wound healing of the outer flap. You can see that this can be used in multiple layers, and again, this protects the bone graft over the top of the membrane. It also helps to prevent early dehiscence, especially with titanium mesh, which sometimes can be an issue. Tension-free closure with Gore-Tex sutures and the placement of the fibrin over the sutures during the first few hours. This is at approximately 5 months. You can see, as I said before, the mesh has a much higher risk of perforation, and where it usually perforates is, as you see here, high up in the mucosa. It won't do it in the keratinized gingiva, but it'll have maybe a small exposure, and this exposed at about 4 months. And we went ahead and uncovered it. You can see the image, the x-ray. Here's the mesh on the very top. Here's the particulate bone. You can almost see it all the way around the implant. And it seems that we've been able to regenerate bone to the top of the implant. And you can see that this material, this mesh, maintains itself very nicely both on the buccal and lingual aspects. So here's the day of removal of the mesh. You can see that we've been able to regenerate a large portion of the bone that was damaged through the infection. And you can see that we've been able to overbuild. Here's the contour of this bone. It's bleeding bone, it's hard bone, and we were able to regenerate it both on the buccal and on the lingual aspects. Now, some of these meshes can be used in many different ways, and we see again the animation to the right of a large defect. It can be done at the time of extraction utilizing these types of rigid meshes. Now, certainly these meshes work quite well. A lot of different companies make very, very nice meshes, which we talked about quite a bit in Craig Mish's webinar just a few months ago, that we need a certain type of thickness that he suggests. But overall, these require small screws, and of course they need to then be removed by raising a larger flap and removing the fixation screws of the titanium mesh. This is certainly possible to do it in this way, but there's also, as you see the left screen, a mesh that will be able to attach to the implant. Now, the collagen barrier or fibrin will eventually resorb, exposing the titanium mesh. The screws can be removed, and then the mesh removed as well, as we did in the case you've just seen. So here on the left is the pre-op after the disinfection of the implant. And then, of course, on the right, you can see the bone that has been regenerated all the way to the top of the machined collar. Again, from the occlusal aspect, you can see the significant regeneration of this previously damaged area around the implant and the volume of bone that has been regenerated on the labial. When we're looking at vertical bone augmentation, or any type of augmentation, but in particular vertical augmentation, some of the common denominators for success are space maintenance, the ability to maintain the space for the regeneration. We show different ways to do that today. The ability to access regenerative cells Of course, the ability to utilize growth factors, whether autologous or recombinant. Bone graft stabilization is very important, whether it be through fibrin or through fixation screws, some form of occlusive barrier membrane, and then of course tension-free closure. Let's take a look at such a case. Here you can see a patient with recession on the adjacent lateral incisor, both labially and interproximally. We have some recession on the right central incisor, and we have a deficiency in the area of the edentulous span. Again, the cone beam CT is taken. We can verify that we have inadequate bone for implant placement. We know that the volume of bone necessary, we can see that in the red on the left screen, so we can highlight how much bone is needed for us to properly place the implant in the area for screw access to be in the cingulum space. Some of the areas of technology make this easier, again, is the utilization of non-autologous sources of bone material. And some of this has been available for quite some time, is the either xenograft or allograft bone blocks. In this case, this is a Zimmer J-block material that is an allograft mineralized irradiated bone. And you can see that we can take the cone beam CT and utilize the 3D technology to have a stereolithographic model fabricated that identifies exactly how that defect looks in the mouth. And we can preoperatively sterilize this stereolithographic model. We can then hydrate the bone block and shape it on the model the same day as the surgery is being performed while the patient is being anesthetized. You can see we can even place the future fixation screws in the area that we're going to need them, and we can shape this block both vertically for the vertical portion of the defect as well as the horizontal portion of the defect. So here you can see the graft being shaped on the stereolithographic model, and on the right screen this is that same block being easily placed in the mouth because it's been shaped prior to the surgery. We're going to utilize the PRGF, which was mentioned earlier, and Dr. Eduardo Anitwa first published on this back in 1997 and 1998 in the utilization of this material in regenerative procedures. And the conclusions were that they had better epithelialization as well as better bone regeneration. And I certainly feel the same way. The PRGF is the concentrate of the plasma-rich growth factors, the best part of the blood that is harvested out through this procedure, and it's pipetted out. So we have a concentrate of growth factors. Out of that amount of blood that we harvest, much of the blood is plasma, and we take only that part of the blood that has the growth factors impregnated in it. We then soak the block graft in the PRGF for a period of 10 to 15 minutes, and then we can go and proceed with the procedure. We're going to see the pre-op on the left and the coronally positioned flap and the horizontal and vertical augmentation on the right at approximately 8 months. And you can see we've been able to augment both vertically and horizontally utilizing this block. The lateral view also displays the buccolingual augmentation utilizing this material. Again, we don't have to go to a secondary site to harvest autogenous bone. And you can see this is what it looks like at approximately 8 months when we're going to place our implant. There are some areas of resorption that we have to take into account. Here you can see a couple of areas of resorption, but overall the screws and the amount of bone that's been harvested and regenerated are quite significant, certainly enough to place our implants. Fixation screws are removed, the implant is inserted, and of course we take the opportunity of regrafting at the time of implant placement. We don't want to take the risk that some of this bone remodels further, compromising our final result. On the left screen is the pre-op, on the middle screen 8 months, and on the right screen approximately 12 months. You can see the process and our ability to augment the implant with the ceramic abutment and all ceramic crown. On the right side, you can see the contours that have been regenerated on the left side utilizing this technique, and we have excellent bone to implant contact all the way almost to the top of the abutment implant connection. So some of the things that we must watch out for with any guided bone regenerative techniques and some of the common complications. Wound dehiscence, one of the most important. We must have tension-free closure. Tissue recession that exposes the membrane or the titanium mesh, as I showed previously. Infection, obviously we want to avoid those things. Difficulty in second stage removal of our materials. Obviously if we can maintain resorbable materials or screws that can be left behind, and of course patient management during the healing phase. Titanium mesh, as I mentioned earlier, may have a little higher perforation rate, and it seems to happen later. Certainly we've seen this with other materials as well, and we need to be able to manage those and maintain and watch the patient during these issues. One of the better articles that I've seen on this was published by Marco Esposito in 2009 in the European Journal of Oral Implantology, and the article was a systematic review of the pertinent literature on horizontal and vertical bone augmentation procedures for dental implants. And what was very interesting is one of his conclusions were that complications appear to be especially true for vertical augmentation, so that we should consider them common and we should be prepared and understand exactly how to minimize them and how to address them when they occur. As you can see here, a patient presents with a very significant vertical deficiency in the area of a missing lateral central incisor. You can see the way that these defects certainly occur after extraction, the loss of the interproximal bone, which is quite common. What is interesting is the interproximal bone on the canine and adjacent central appear to be type 1, so we're really only dealing in the area interproximally between the two future restorations, two missing teeth, where the vertical defect seems to be the most severe. So the attempt will be to augment this in a rather efficient manner. And again, cone beam CT allows us to look at different areas of bone harvesting that we can utilize. There's different areas of the mouth. Some patients do have good and solid bone even in the maxilla, the tuberosity, the anterior nasal spine. Of course, we know about the chin and the ramus, and there of course is palatal bone harvesting, which was beautifully shown on this site during a webinar by Dr. Gluckman. So I'm going to use the same technique, the bone transport system. I'm going to harvest tissue as well as bone that I'm going to harvest. And I'm going to also, in many of these cases, attempt to harvest bone, if needed, from the palate or from the anterior palate or from the anterior nasal spine. Again, these are other areas of bone harvest. Here's the type 3 defect we've identified, again, utilizing cone beam CT. It is identical to what we expected. And today, utilizing the Meisinger 1mm fixation screws, they're very small screws that can be utilized to secure these small block grafts. As you see here, I have 4 block grafts that I've harvested utilizing the Trefhines. You can see 1, 2, 3, and 4 mini screws placed to fixate these blocks. And these blocks are really important because they're rigid, they maintain space, and obviously they're autologous in nature. And you can see one of these blocks was actually removed from the anterior nasal spine and then secured in position. The interproximal bone on the adjacent teeth remains ideal, so really the idea is to augment as much of the inside in the area of the missing teeth as possible in between the area of the future restorations, the lateral and central. So here's the vertical support for the future restorations and implants that will be provided. We then mix mineralized irradiated bone with PRGF. We utilize the fibrin in layers, as I have shown you in all of my previous cases. This is routine in my practice to use a blood-borne bioactive material, and this has worked very, very well for us. You can see how this material turns from a bright yellow to a pale yellow material as it starts to firm in the mouth Usually that's about 2 to 3 minutes of working time, and it forms a very, very nice protective apron, if you wish, with bioactive materials over the bone graft. Now you can see us working our blade to split and dissect the flap to attain tension-free closure and to coronally position the flap. This is done in the elastin fibers of the mucosa and extends deep into the vestibule. Here's what it looks like. Here's the temporary bridge. You can see how we've been able to fabricate this and bring down the bone. And in the area interproximally where the future papilla is going to need to be, we're going to place a piece of keratinized tissue from the palate as additional graft material where we will need thickness. So we're going to use that tissue and we're going to secure it to the outer flap prior to closure. Here is the graft, the CTG, secured with a horizontal mattress suture or an anchor suture, and now I'm going to bring this flap and close it utilizing, again, horizontal mattress suture that you see here, utilizing Gore-Tex sutures. Complete closure over the grafted area, and then the temporary restoration placed without pressure on the ridge, just with limited contact, no pressure. It's very important that there's no pressure. You can see the Gore-Tex sutures, and now as the patient heals, we'll get some swelling over the top of these pontic sites, which will allow us to have an ideal area for future implant placement. Here is the pre-op on the left, and then the post-op at approximately 4 months before implant placement. You can see these small screws that are now available for us really makes the utilization of small autologous blocks very, very efficient and much, much easier to perform clinically. So really another way of augmentation here, the vertical defects, utilizing again bone transport and the 1 millimeter Meisinger bone fixation screws. We published an article a few years ago with my friends from Japan, Tom Ishikawa, Aki Funado, Hajime Kadajima, and of course our team here in Atlanta, where we really described the three-dimensional requirements of bone and soft tissue for optimizing aesthetic results in compromised cases with multiple implants. And this has really been part of our learning curve over the many years, is how to augment and be efficient in these types of severe deficiencies. And as you can see here, the case done by my dear friend Tom Ishikawa, where a significant defect was regenerated over multiple procedures, and you can see getting a very, very beautiful result. This is the case that is highlighted in the article, and you can download it from dentalxp.com. It was published in 2009 in the International Journal, 2010, I'm sorry, in the International Journal of Perio and Restorative Dentistry. So as an overall review today, I'd like to just summarize the common denominators for success. I think it's important that you maintain space. There are many different membranes available, and on a future webinar, I hope to bring you some more information in regards to vertical augmentation in particular, and some of the new techniques available. Access to regenerative cells, whether it be through autologous sources of bioactive materials or whether it be through intramural penetration of the surrounding bony walls. Growth factors, we have BMP2s, we have recombinant PDGF, as well as, of course, the autologous blood-borne bioactive materials. Bone graft stabilization, utilizing some of the smaller diameter fixation screws as mentioned during the program. Of course, occlusal membranes. We have titanium today that was featured, collagen, fibrin, but we have many, many others that we will talk about in future webinars. And of course, tension-free closure that can be maintained throughout the healing phase. I'd like to take the opportunity to thank you for your time with me today, and I hope that you'll take the opportunity to submit some questions to us. And of course, again, I hope that you'll take the opportunity to join us in Las Vegas for the Global Symposium in February 2013, February 7th to the 9th. I think it will be a fantastic event, and I hope that you'll take the opportunity to be there with us. Thank you very much for your attention this evening.